Medicare Advantage, or MA plans, are another way for beneficiaries to get Medicare Part A and Part B coverage delivered through private insurance companies. MA plans adhere to the rules set by Medicare to cover beneficiaries, but their benefits are delivered by Medicare-approved private companies. MA plans are part of a broader trend towards public sources of coverage, like Medicare and Medicaid, increasingly relying on private health plans to provide or administer their health benefits. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hederle with AHA Communications. Last year, 42% of all Medicare beneficiaries got their benefits through private MA plans. Enrollment in these plans is growing at nearly 10% per year. There are serious concerns that coverage and patient access are being eroded as a result of health insurer efforts to restrict access, and that there is a tremendous burden on healthcare providers to manage these insurer policies. In fact, the HHS Office of Inspector General recently published a report finding that MA plans have exhibited a pattern of denying prior authorization and payment requests that would have been covered by original Medicare. These types of denials have raised fears about certain insurer practices which may impede beneficiary access to medically necessary care. Joining me to discuss how the trends around Medicare Advantage may affect patient care is Michelle Millerick, AHA Senior Associate Director of Health Insurance Coverage.
Michelle, thanks again for coming on the podcast.
Thanks for having me.
Can you tell us more about the growth in these products? What's going on?
Yeah, absolutely. So as you alluded to in your introduction, we're just seeing huge and rapid growth in enrollment in Medicare Advantage. And to just give you a sense, over the past decade, it's more than doubled. So back in 2011, we had 12 million enrollees, and now in 2021, there is 26 million. So it's almost half of all Medicare beneficiaries are getting care through these sort of private companies that contract with the government to provide Medicare beneficiaries. And I'd also note that there's a lot of variation by state. So in some states, we see way more than half of all Medicare beneficiaries getting plans, or getting care rather, through Medicare Advantage. And in others, like in Alaska, there's hardly any sort of managed care penetration. So it kind of varies by state, but overall, we're seeing a lot of growth. There's a number of different factors that are convalescing together to drive this growth. One, an aging population, so there's just more people that are eligible for Medicare and may choose Medicare Advantage. Also, CMS, as the Centers for Medicare and Medicaid Services that administers the program, has been, really an advocate of sort of creating pipelines to move patients from original Medicare into managed care models, which is what Medicare Advantage is. So we see that sort of as a gateway to Medicare Advantage, where more people are sort of moving or shifting or opting for that private coverage in Medicare. Also, from our perspective, it's an increasingly lucrative market for MA plans, or the private insurance companies that offer these products. We're seeing huge health plan margins in the MA space that are, for a lot of the plans, like they're making more money in this segment of the market than they are in commercial insurance. And so that's driving a lot of their behavior. You're seeing the big players in that space increasing their footprint in the market. You're seeing new health insurance companies pop up to enter the Medicare Advantage market. And in some ways, really sort of like saturating, there's some beneficiaries have 3,000 plans to choose from. So from a consumer perspective too, thinking about all the choices that people have and sort of the ability that they have to digest that. And then I think the last thing is that some of these plans, the growth in them are really driven by consumer choices as well, that some of the MA plans compared to original Medicare have out-of-pocket maximums, or are able to offer different benefits like dental or vision coverage that are attractive to consumers that aren't available through traditional Medicare pathways. So I think that's one of those other things that's attracting more people to enroll in those products.
But, as we were talking about a moment ago, we're implying that there is a potential downside here. What's the big problem with more people enrolled in these plans, and what are the concerns about the impact these plans are having on patients and healthcare providers?
Yeah, absolutely. So, I think MA sort of aligns with our concerns about many commercial insurance strategies in general. So, we see health plans that are using, especially with MA plans, a lot of strategies and tools to decrease their cost, but in ways that often reduce access to care for patients, or add cost and burden to the healthcare system, whether it's sort of restricting or delaying sometimes access to care. And so these are things like excessive or inappropriate prior authorization, or other tools that we call utilization management techniques that sometimes can cause substantial delays or negatively affect patient care. And, to be clear, these are things that when used appropriately can help to align sort of patients' care with their insurance benefits. But oftentimes in sort of the cases where we have concerns, it's places where it's inappropriate use of prior authorization or it's excessive and some of these, behaviors that affect patients negatively. Like that's what we're concerned about. And I think our members, we hear from them that this is really egregious in the MA space, which is why we're talking about it today. And just to give you a sense, there's a sort of an example from one of our members that was caring for a patient with newly diagnosed diabetes, and that patient presented with a fasting glucose blood level that was at a critically dangerous level that was about 5 times the acceptable range. And this, the clinician who was taking care of this patient learned that they could not give insulin to that patient immediately when the patient presented, which is what they were clinically indicated to do, because they had to ask that person's health insurance plan for permission to do that. And the plan said that they would take about 24 hours to do that. And so the clinician in this case had to go sort of rummage to find some insulin samples to give this patient who's presenting in a really critical situation to remedy that. And thankfully that clinician was able to do that and provide a sample while waiting for the health plan. But those are the kinds of sort of delays in care. Insulin has been widely available for more than 100 years. There's not a lot of evidence that it's overused or misused. It's not extraordinarily expensive in most cases. But these sort of plan policies that really interfere with a clinician's ability in the moment to take care of somebody who's presenting with an emergent condition that can be easily remedied.
Well, if we can stay on that point for just a sec, because I'm curious, whether a Medicare Advantage plan is accessed through a private insurer or through the government, they theoretically are all playing by the same set of rules, right? So why would there be a disparate impact in something like getting insulin to somebody who desperately needs it?
I'm so glad you asked that, because I think that is one of the things we think about a lot, that there should be equity or parity between people enrolled in original Medicare versus those in MA. And the MA plans do have some degree of latitude to put on prior authorization and some of these other utilization management tools that don't exist in original Medicare. So there really isn't a substantive prior authorization policy in Medicare. And it's actually one of the main sort of policy issues and concerns that we have, that sometimes these MA plans are putting out policies that are more restrictive than those that exist in Medicare. And we see that as a huge equity issue and a huge parity issue.
Do you think that federal regulators, are aware enough of the problem to start paying some attention to it and coming up with some solutions?
Yes, absolutely. I think that's certainly part of our job in, raising that flag about some of these issues on behalf of our members and on behalf of their patients. I do think federal regulators are sort of increasingly seeing some of these problems, and I think in some of the sort of recent Medicare Advantage proposed rules, you see some additional health plan oversight provisions that are starting to come out. So I do think we're getting some traction on these issues, and I do think that the patient voice in expressing some of these barriers and delays and confusion that these policies cause, really does make a case to regulators that some change might be needed here.
What are some of the things that MA plans could be doing to operate more efficiently and to ensure that patient access is not inhibited by administrative policies?
Yeah. So I think there's a lot of opportunity to enhance these processes to make them work better for patients. And I think a lot of those things revolve around standardizing processes and in some cases where it's appropriate, finding ways to hold health plans who have abusive practices or who are doing things that hurt patients, to hold them accountable for that behavior. On the standardization side, prior authorization that we've talked about a couple of times, every plan has their own version of that, to what services it applies to when it's needed, to the way to request a prior authorization. Do you need to call? Do you need to use a fax? Do you, need to use an electronic portal? Do you have access to that? So there's like all these different things that sort of impact, the rules for each plan, for each patient, for each service. Standardizing some of that or having some alignment, across plans or for different types of services would be helpful. And we hear from our members a lot, too, around the timeliness. I mentioned in that case with the insulin that they needed 24 hours. In some cases, especially for, maybe a patient being transferred from a acute care hospital to a post-acute care setting, we see days, go by before an answer is received about whether the health plan will sort of approve that. And so we see it as really important that there be some time frame set on that for, maybe it's a little bit longer for something that's a scheduled, foreseeable procedure, maybe 72 hours, but something that's urgent, it really should be 24 hours or less that they're getting a response. So those are a couple of the things that we're seeing. And I think the last thing I would note is that we often think about the fact that there isn't standardized reporting available about health plan appeals and grievances and information about how much prior auths that are, how long it takes for the plan to respond, or about the denial rate, or how many, when a provider appeals or a patient appeals, how many of those are overturned in favor of the provider or the plan. And so we think public reporting on some of those measures that really are important indicators of access, but are often not known in a public or transparent way, could really help policymakers as well as others understand better what's going on underneath the hood here, and to provide a little bit more insight into where intervention might be needed.
Well, I think we're just about out of time. So, Michelle, thanks so much for coming on the podcast today to talk about this. Really appreciate your time. You've been listening to a discussion of Medicare Advantage with Michelle Millerick, AHA's Senior Associate Director of Health Insurance Coverage. This is Advancing Health, a podcast from the American Hospital Association. Thanks so much for joining us.